Hello, I'm Dr. David Dodick. I'm a professor of neurology at the Mayo Clinic in Arizona, and I welcome you to this program entitled Getting to Grips with the Science of CGRP and Migraine. Joining me today is Professor Richard Lipton, who is a professor of neurology at the Albert Einstein College of Medicine and the Headache Center at Montefiore in New York. Welcome, Dr. Lipton.
Well, thank you.
So this program will include a discussion of off-label treatment and investigational agents not approved by the FDA for use in the United States, and data that were presented in abstract form rather than full publication. These data should be considered preliminary until published in a peer-reviewed journal. So Dr. Lipton and I are going to ask each other questions today surrounding the exciting evolution of CGRP and therapies that target CGRP. So we're going to start with Dr. Lipton. So Dr. Lipton, ask me anything.
Okay, so why don't we start with the evidence that CGRP plays a role in the pathophysiology of migraine?
So, I think it goes back about 30 years now, where CGRP, the peptide, was first discovered in pain fibers that innervate the cerebral blood vessels. And back then, of course, we thought that it was the distension of those blood vessels that led to the pain of migraine. So it was hypothesized as long as 3 decades ago that CGRP may be involved. Now, fast forward 30 years, we know that CGRP and its receptor are located on pain fibers in the trigeminal ganglion, in the peripheral trigeminal vascular nerve fibers, but it's also located centrally throughout the brain in areas that process pain and modulate pain. So it's in the right location. We now know, however, that CGRP levels in the blood rise during an attack. They go back to normal basically after the attack is over. So for example, when you treat with a triptan and you relieve pain completely, those elevated levels of CGRP go back to normal. So based on that, and based on the fact that when you actually administer CGRP parenterally to an individual with migraine, they will develop an attack invariably that's indistinguishable from their spontaneous attacks. So a lot of circumstantial evidence that would suggest that CGRP plays a very pivotal role in the pathophysiology of migraine.
And then, of course, there's the evidence that emerges from the fact that treatments that target CGRP are effective in migraine.
Precisely. So speaking of that, what is the difference, tell me, between treatments being developed that target the CGRP pathway? Because there are small molecules being developed, and then there are biologics that have been developed.
Right, so the small molecules are called gepants. They're conventional drugs that can be taken by mouth, and there are 3 agents that are pretty far along in development that are in this family of gepants, which are small molecule CGRP receptor blockers. 2 of them are being developed as acute treatments, rimidripant and ubrogepant. One of them is being developed as a preventive treatment, and that agent is called atogepant. In addition, there are 4 antibodies being developed as preventive agents for CGRP. Because the antibodies are proteins, they're given by injection. The antibodies are all being developed as preventive therapies. One of them targets the CGRP receptor itself, and that's the agent that is currently approved in the United States, Erenumab. It's a preventive treatment for migraine. The other 3 drugs target the CGRP ligand and not the receptor.
Now, with regard to the evidence base, so you've told us that there are small molecules being developed for both the acute and the preventive treatment of migraine, and biologics or monoclonal antibodies that target the pathway that are being developed for prevention.
Right.
The evidence?
Well, so the evidence for the small molecules being developed for acute treatment is really quite robust. There have been 2 double-blind placebo-controlled trials for each of the small molecules in the acute treatment of migraine. The results are very similar, actually, across the 2 molecules and across all 4 studies. All 4 studies hit their primary endpoints in migraine clinical trials, and those primary endpoints were being free of pain 2 hours post-treatment and also being free of whatever is the patient-designated most bothersome symptom at the time of the treated attack. For the small molecule preventives, there's a phase 2 study whose results are still in abstract form, but that study also demonstrated that atogepant works as a migraine preventive. For the monoclonal antibodies, there are multiple studies in episodic migraine and chronic migraine. One of the most astonishing things about the studies of CGRP targeted therapies is they seem to always work.
Yeah.
And you know, in headache neurology, we have kind of a ho-hum attitude about that because we're used to this extraordinary string of positive studies. But as somebody who spends time in Alzheimer's also, I know how much we should be grateful
Yep.
for this winning streak.
Yeah, absolutely.
So let me ask you, Dr. Dodick, what are the advantages of monoclonal antibodies over currently available treatments?
Yeah, so good question. I mean, when you look at the overall response rates in clinical trials, i.e. the percentage of patients who get a 50% reduction in the frequency of migraine or in monthly migraine days, as is usually the primary endpoint, they're roughly comparable to some of the preventive oral treatments that we currently use. However, I think what the difference is that number one, obviously the pragmatic difference of having a subcutaneous injection once a month or a quarterly infusion intravenously compared to having to take a small molecule daily, once daily, twice daily, or 3 times daily. So I think that's one difference. The other difference is that typically we talk to our patients, and we have for decades, when we're starting them on a prophylactic medication, we tell them to start low, go slow, we titrate the dose, and to be patient, because it may take 2-3 months to notice a significant effect. What we're seeing with these new monoclonal antibodies now is that they get the onset of effect, depending on how the antibody is administered, sometimes within 24 hours, certainly within a week. I think there's data for all of the antibodies now to show that the onset of effect or the separation from placebo occurs as early as a week. That's not to say that there isn't a cumulative benefit over time, but they work quickly. I think the other advantage, is the tolerability. Thus far, in all of these trials in episodic and chronic migraine, there hasn't been a serious treatment-related adverse event. And by and large, with all of the antibodies, the side effect profile appears comparable to placebo. That's the game changer for me, because while response rates at 3 months with oral prophylactic medications look comparable, the fact that over 80% can't adhere to those oral treatments 1 year later means that if you can't adhere to treatment and you don't continue with treatment, you don't continue to derive the benefit. So I'm hopeful that long-term treatment outcomes with these antibodies will be much more robust because patients will be able to stay on them and take them. So I think those are some of the main advantages, with the antibodies compared to currently available oral drugs. So let me turn this back to you, since we talked about prophylactic therapy. You talked about GPANTs, the CGRP receptor antagonists. What advantages do they have over currently available acute treatments?
Well, certainly the most widely used acute prescription drugs for migraine in the United States and many other places are triptans, and triptans were a real game changer when they came on the scene in the early and mid-90s. But no drug is a perfect drug, and triptans have several issues or problems that I think the GPANTs may be able to address. One obvious thing is that triptans don't work for everyone, and so having other molecular targets will be advantageous to treat people who don't respond to triptans. Mm-hmm. There are a set of adverse events that we actually call triptan sensations or triptan side effects. They include flushing and sweatiness. They sometimes include chest pain. Mm-hmm. The GPANTs don't have those side effects. So for people who have tolerability problems with triptans, the GPANTs will be very helpful. In addition, the triptans were really developed to be cerebral selective vasoconstrictors. Yeah. And the difficulty with being a vasoconstrictor is that in people who have a history of heart attack and stroke, and people who have certain conditions, angina, claudication, ischemic colitis, and even in people who are at high risk for cardiovascular disease without conditions or events, triptans are absolutely or relatively contraindicated. And we've estimated that there are perhaps 3.5 million of the 40 million Americans who have migraine who fall into that category. And so treating people with cardiovascular problems is certainly an issue for the triptans, and the gepants are not vasoconstrictors, and they should be free of the cardiovascular liability that we see with triptans. And then finally, most classes of acute migraine medications cause overuse. So if the drug is taken too often, it becomes a cause of more headache. And sometimes that's called medication overuse headache, sometimes it's called rebound headache.
Yeah.
Because the gepants work as preventives, we're very hopeful that we won't have that problem with medication overuse. So currently, the advice we give our patients is, well, you want to take your triptan as soon as possible when you know a headache is coming, but don't take it too often.
Yeah.
And the patient says, well, what am I supposed to do? And the hope is that with gepants, people will be able to treat early without fear of medication overuse syndromes.
So it will fill a huge unmet treatment need for a lot of patients.
I am very hopeful that they will, yeah.
Yeah.
So can you summarize the evidence that the monoclonal antibodies that target CGRP pathways are effective and safe and well tolerated?
Yeah, so, thus far, as you outlined, there are 3 antibodies that target the peptide. There's one antibody that targets the receptor. The one that targets the receptor, arenimab, has been approved by the FDA for the prevention of migraine. So it's been shown to be effective in episodic and chronic migraine. 2 are under FDA review, and we hope that if everything goes according to plan, we may see those within the next several months to a year. And then the 4th, which is a parenteral or intravenous monoclonal antibody, is completing its phase 3 studies right now. Thus far, all of the studies have been positive. They've met their primary endpoint. Their primary endpoint usually is the reduction in mean monthly migraine days, either at the 3rd month after treatment or the 6th month after treatment. So all have been shown to be effective. And largely, roughly speaking, that the response rate, or the proportion of patients who have a 50% reduction in mean monthly migraine headache days, is around 50%. It varies. Somewhere between 45 and 60% depending on the antibody, but so too does the placebo response vary. But if you look at placebo-subtracted responses and the overall magnitude of the responses, by and large, these antibodies look comparable in terms of the response rate. Now, there are a subgroup of patients who get a very robust response. So about a third across all of these antibodies, about a third of the patients treated have a greater than 75% reduction in the frequency of migraine headache days. And that's relevant. So clearly there's a subgroup, and hopefully we'll be able to identify that subgroup who appears to be particularly responsive. And then some of the data being presented recently, if you look at open label extension data out to 1 year or even longer, for patients who are able to adhere, we're seeing 50% responder rates that approximate 70%. We're seeing 75% responder rates that are between 45 and 50%. And we're seeing that fully almost a quarter of patients become migraine-free. So the longer one is able to stay on these antibodies, the more robust the efficacy over time. So it's very encouraging, the kind of responses that we're seeing with these antibodies.
Yeah, I would agree, and I've never seen anything like the super responders that are the people who have a greater than 75% response rate.
And now it's up to us to try to identify who those patients are. I also think, too, though, that the way we define response in a clinical trial is arbitrary.
Yes.
So there are patients in practice, as you and I know, that respond dramatically to a particular therapy, and yet they may have daily headache. So if you drop someone's pain intensity from an 8 to a 2 and drop their exacerbations, you can dramatically help an individual like that who would otherwise be a treatment failure in a clinical trial. So I actually think that the results of the clinical trials will likely be generalizable to clinical practice, and we may even do a little bit better in practice because A, we're not using placebo, and B, patients define for us what a response is, and don't hold us to the rigidity of the clinical trial outcomes that we use in clinical trials.
Yeah, so I completely agree with what you said about reduction in pain intensity, and another factor is a reduction in pain duration.
Yeah.
So in trials we count days with migraine, but if somebody goes from 18 hours of pain to 5 hours of pain. Our clinical trials endpoints might not identify those people, and yet it's life-changing for our patients.
Absolutely. So let me ask a final question, Dr. Lipton, and that is, where do you see these fitting into practice, these monoclonal antibodies? I mean, we have one approved right now. Where do you see them fitting in, and what patients would you consider when they present to your office eligible for a monoclonal antibody?
Well, so I think it makes sense for a patient who needs a migraine preventive drug to begin with relatively low-cost oral generic medications. But I also think that there are many people who don't get the benefits we're looking for when we give them oral generic preventives, either because they don't get the level of efficacy that they require, or because they develop side effects that are intolerable. Mm-hmm. So I think for many people with chronic migraine, these drugs will be invaluable, and for people with lower frequency migraine who don't get the responses we're looking for from oral generics, I think they'll make a big difference. And I want to highlight a point you made previously, which is that with many oral generics, there's a balance between efficacy and tolerability. So a patient may be on a drug, they may be a good responder and have a 50% reduction in their monthly headache days, but they may have tingling or cognitive toxicity or other adverse events, and they have to make a difficult judgment, weighing the benefits of treatment against the side effects they're experiencing. And the thing that's so exciting about the monoclonal antibodies is that people really don't need to make that trade-off. They have days when they are absolutely crystal clear, not suffering from migraine, not suffering from symptoms related to migraine that occur between attacks, not suffering from medication side effects. And I think that really is a game changer. Yep,
absolutely. Well, thank you, Dr. Lipton. I'm sure we could sit here and talk till tomorrow about this, but you and I have done this for a very long time, and I've said that we love what we do, but now it's fun, and now it's fun. I mean, because we're able to provide hope, and we're confident in our ability now to deliver relief to patients, and tolerable relief. So I don't think there's ever been a time for patients to be more hopeful than now.
I really agree. Thank you.
Thank you. So thank you for joining me today, and thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.